Pasquale, and I'm a student at Cedar Crest College. And today I'm going to be presenting an article titled Effects of Correction Insulin and Basal Insulin on Inpatient Glycemic Control. This study was conducted due to the amount of patients with diabetes type 2. Diabetes affects millions of people in the U.S., and glycemic control is challenging in both the healthy individual and the hospitalized patient. One reason for the difficulty in the hospital is because insulin needs fluctuate with acute illness and increased stress, so therefore they need to be monitored more effectively. The authors describe the purpose as describing glycemic control of two groups of patients diagnosed with diabetes type 2 receiving subcutaneous insulin via two different regimens. So basically they were testing the effectiveness between two insulin therapies, one being correction insulin only via the sliding scale, and the second being a basal insulin plus the correction insulin. One of the reasons this study has been done is because they said there have been few studies on the difference between the effectiveness of these two groups. The study is significant to nursing practice because with the increased people with diabetes mellitus, nurses need to be aware of signs and symptoms of both hyper and hypoglycemia so they can alert the physicians and the appropriate methods can take place. This study was a descriptive retrospective design, which just basically meant the researchers collected data from past events. The independent variable for this study would be the subcutaneous insulin being either the correction insulin via the sliding scale or the basal plus correction insulin. And then the dependent variable would be the blood glucose levels or the glycemic control because the insulin had an effect on what those outcomes would be. A research variable for this study would be the demographic data, and this would include such things as the subject's age, weight, race, date of admission, types of medications being taken, and etc. The sample, the researchers originally collected 90 patient records from a 535-bed Southeastern hospital in the United States. The sample inclusion criteria included admission to the hospital within prior year, a history of diabetes type 2, length of stay 4 days or greater, current inpatient insulin prescription, current oral diabetic medication prescription, diagnostic related groups of selected medical conditions, and then the exclusion criteria would be admission for a surgical procedure, inpatient prescriptions of steroids, thiazide diuretics, or niacin. Also, if the patients were receiving enteral feeding or total parenteral nutrition, if they had a diagnosis of renal failure, liver failure, COPD, diabetic ketoacidosis, or pancreatitis. They also included patients who were admitted to the ICU or if they had an inpatient prescription of IV insulin. So, following the review of those 90 records, the researchers concluded that only 45 of the records could be used to complete their study. 23 of the subjects were receiving the correction insulin only via the sliding scale, and then 22 of the subjects were receiving the basal plus correction insulin therapy. Prior to analyzing the data, the researchers got approval from the International Review Board and HIPAA from the University of North Carolina at Greensboro. The data were collected on an electronic documentation system which was a point-of-care database. For each subject, the researchers were looking at 4 different blood glucose levels taken each day per patient. There was one which would be the fasting blood sugar, which was taken before breakfast. The next would be the blood glucose levels before lunch, then the blood glucose levels before dinner, and the blood glucose levels before going to bed. Then with each of these levels, the researchers determined whether they were hypoglycemic or hyperglycemic. For hypoglycemic, the capillary blood glucose level would be less than 60 milligrams per deciliter, and for hyperglycemic, the capillary blood glucose levels would be over 180 milligrams per deciliter, or a fasting blood sugar greater than 130 milligrams per deciliter. The results, overall there were 540 capillary blood glucose levels taken from the subjects. 302 of these levels were classified classified as hyperglycemic, which was over 50% of the capillary blood glucose levels. They also found that the sample age ranged from 30 years old to 70 years old, and in the basal plus correction insulin group, the trending values for hyperglycemia were higher. There were 185 out of 264, or 70% of the capillary blood glucose levels collected were characterized as hyperglycemic, whereas for the correction insulin only group, there was 117 out of 276, or 42% of the capillary blood glucose levels collected were identified as hyperglycemia. Another finding that they found, which was relevant, was that in the basal plus correction insulin group, the fasting blood sugar had a significant decrease from day 1 to day 3, whereas in the correction insulin group there was no significant decrease in the fasting blood sugars. Also, they found that 1% of the capillary blood glucose levels collected were hypoglycemic, but they didn't think this was significant. Some limitations they identified, one being the sample size. Of the 90 original records they were going to use, only 4 to 45 of these records met the criteria, which then they also found that the subjects were taking various oral medications, which could have affected their blood glucose levels. The subjects had varying degrees of diabetes, which also would affect the blood glucose levels, as well as comorbidities experienced by the subjects or stress levels, which would additionally affect blood glucose levels. Implications for nursing practice. One of the most important ones is for nurses to know what to do if one of their patients is experiencing hyperglycemia. And that would be that the nurses should alert the physicians as soon as possible in order for them to adjust the insulin orders. They also should identify signs and patterns of both hyperglycemia and hypoglycemia, as well as situations that put patients at increased risk for hyperglycemia, which would be like stress, acute illness, taking steroids, and infection. They also should be educated more about monitoring blood glucose levels and how to do the whole carbohydrate counting when it comes to the sliding scale. And then in conclusion, the researchers feel that there should be future research conducted on why nurses hold insulin and how this can be done appropriately. Nurses should be aware of the appropriate times to hold insulin, because holding insulin can lead to a sustained level of hyperglycemia. And they also believe that intensified insulin therapies need to be implemented and adjusted accordingly to achieve a tight glycemic control and better health outcomes in the patients. And this is the reference for the study that was used. Thank you.